Most of these are quite stable. They are quite well aligned, especially a neck fracture like this, which is impacted. How do we know it's well aligned? You can see clinically the alignment. If the child is able to make a fist with good alignment, no pain, then these are very stable fractures. These can be treated with plasters or splints. Similarly, these fractures on X-ray do show some malalignment, but again, check it clinically. If the child is able to bend well, there is no scissoring, there is no stiffness, minimal pain, then we know these are stable fractures and these can be treated with buddy taping or strapping. However, kids are notorious that they'll keep using the hand. Hence, I prefer to put them in a strap and give them a plaster, or I put them in a boxing glove dressing. This makes the child understand that he or she is not supposed to use the hand. This gives you good results because otherwise the child will keep using the hand and a simple fracture may end up displacing and you might need to end up operating the child. Occasionally in children, malalignment may be tolerated, especially if it's in line with the range of movement of the finger. So that's the sagittal malalignment. A coronal malalignment may not be tolerated that much. How do we know? Again, ask the child to flex the finger. If the child is able to move well without pain, without scissoring, this can be accepted and you'll realize that this will remodel over time. Well, not all fractures will remodel, not all fractures will keep the alignment. Hence, it's necessary that any fracture that you treat in a pediatric age group, you have to follow it closely. You need to see the child frequently, every 5th day, maybe every week. Open up the dressing, open up the strapping, just check, ask the child to move and see whether the child is still moving well. If not, then you know something is wrong. And if you catch it early, you will end up doing a simple procedure like a close reduction and fixation. Otherwise, if you miss it and the child comes to you at 3 or 4 weeks, then you might have to do an open reduction. Something like this, this was missed and the child had stiffness and deformity. So most of the fractures can be treated like this, but there are certain fractures, especially the base of proximal phalanx fracture. The child presents with a lot of pain, anxiety, a lot of deformity and stiffness. These are very unstable fractures. Yes, you can try to reduce them in flexion and keep them in a flexion splint, but ensure that you get good X-rays after putting them in flexion because these usually displace with time. For these, a simple close reduction and anesthesia followed by 2 cross-K wires is ideal. These are small wires, 1 millimeter or 1.2 millimeter, and try and cross these, put a cross fixation. Sometimes the bone is too small, all right? So sometimes you may not be able to put the second wire, and if you feel that way, then you try and pass at least 1 wire and engage the metaphyseal beak. In a Salter-Harris type 2, you'll have a metaphyseal beak. That will give you a better fixation than a wire from the opposite side. Again, immobilize and check regularly. The other common fractures, these look very simple. Yeah, I'll reduce it and put wires. Means I have found it a lot of difficulty in putting these 2 cross-K wires. But yes, close reduction does help, followed by these small wires. Or if the fracture is proximal, you can have some intramedullary fixation like this. Condylar fractures, again, they look simple, but they are very difficult. They always displace. When you try close reduction, you may not be able to get the fixation right. So you can use a small wire, pass it into the fragment with your hand or a T-handle, use it as a joystick to reduce the fragment, and then transfix it with wire, and then drive the joystick wire down, and you end up having a good fixation. Sometimes you may not be able to do a close reduction. I've done about only 3 of them in my 8 years of practice, and I find it very difficult to open a neck fracture in a child. The fragments are small, so try and use simple wires, open it, use a wire to joystick, put it back without much handling of the fragment, and then you can have a good reduction. I'll touch base on Seymour but not discuss it. This is fairly commonly missed injury. Always remember, check the dorsal aspect of the finger. If there is ecchymosis, subungual hematoma, try and get an X-ray of the opposite side and compare, because this is a fracture that cannot be managed without surgery. This needs surgery. In short, most of the pediatric fractures are amenable to straps and plasters. However, they need close follow-up. If you pick them early, you can do a close reduction and pinning and get away with good result. And make sure that you have these small wires in your armamentarium.